Welcome, everyone. Today we have the pleasure of having an essential virtual cafe talk within the framework of the European Haemophilia Consortium educational and awareness raising program on aging. I'm delighted to be joined by our clinical experts to explore how we can support older adults in maintaining strength, balance, and confidence, while also managing the unique challenges that bleeding disorders bring. It's my great pleasure to welcome you to the virtual roundtable today and introduce you to Stephanie Taylor, specialist physiotherapist from Oxford Haemophilia and Thrombosis Centre in the UK, and Dr. William McKeown, consultant geriatrician and stroke physician at Queen's University Belfast in the UK, EHC Steering Committee Member, and advocate for healthy aging. My name is Daria Camilli, and I'm Educational and Communication Manager at the European Haemophilia Consortium and the host of this program. To start, I'll share one of my personal biggest fears about aging, a hip fracture. For as long as I can remember, practically in every family that I know, someone from the older generation has had a hip fracture. Some recovered afterwards, while others remained bedridden for the rest of their life. Now that I've started with this very scary things, William, could you help us understand what are the main factors that increase the risk of falls in older adults and how might these differ for people with bleeding disorders?
So almost all falls in older adults are multifactorial, i.e., they have multiple causes. So it's never as simple as one thing caused the fall. It's usually multiple things have contributed to that. And actually, that's a good thing because it gives us lots of opportunities to intervene and prevent future falls. So things that increase your risk of falls most significantly are previous falls, muscle weakness, taking multiple medications, having a memory problem like dementia or delirium, poor eyesight, blood pressure that's variable, and living in a hazardous home environment with lots of trip hazards. Um, so all of these are examples of things that we can act on to reduce people's future risk of falls. And certainly within the bleeding disorder community, some of these may occur at a higher frequency. So things like taking multiple medications, being in pain, and having joint damage.
How early should we start talking about fall prevention with patients who have bleeding disorders?
So the biggest single predictive factor for future falls is previous falls. So anybody who has ever had a fall, I think we should be talking to about preventing falls and looking for opportunities to intervene. But actually, there are lots of earlier subtle signs that predict future falls even before the first fall has happened. So people who have had slips, trips, or almost falls, these people we know are all at increased risks of further falls. We know people who walk more slowly are at increased risks of further falls. So a good example of this is, can you cross the road before the lights change? So in the United Kingdom, all traffic crossings are programmed for a walking speed of 1.2 meters per second. If you cannot get across the road before the lights change, you're a slow walker. You're somebody who is at increased risk of falls. So um, there were so many warning signs. Another one that I commonly look for in patients is, can you get up from a chair without using your arms? If you can't get up from a chair without using your arms, it suggests you're already starting to lose muscle in your lower limbs, in the big muscle groups like your quadriceps. So there's lots of early warning signs that I think should prompt us to talk about falls and falls prevention. Um, Specifically for people with bleeding disorders, I don't think we can give a definite age at which we should start talking about falls prevention because even within the bleeding disorder community, aging is very, very variable. But that age is likely to be younger on average in people with bleeding disorders. So falls rates for people with haemophilia in their 40s are similar to those for the general population in their 60s. So we can't give a specific age, but we can say it's likely to be earlier. I do hope, though, with improved treatment, that might no longer be the case in the decades to come. But for now, when we see these warning signs, we need to be talking about falls prevention, and it's likely we need to talk about it earlier for people with bleeding disorders.
Thank you, William. Stephanie, could you please develop a bit more on the other warning signs that mobility might be declining?
So, yeah, so William's covered those really well. So mobility, I'd say, depends on sort of multiple factors of health. So William talked about muscle strength, your joint mobility, how good your balance is, and also your confidence to move are all really important that you need to be looking at. And also, certainly when I talk to my patients, what's happened in your lived experience will also influence how confident you are to do some of these things. And we know that our muscle mass decreases with age. And there's a medical word called sarcopenia that you may hear. And we build our muscle and bone at a young age. Really, from the age of 30, that slowly declines. And certainly from the age of 60 in the general population, we're losing up to 1% a year. It's sort of stated in the literature. And that's tricky for patients with haemophilia. So you may have grown up being told not to be active, bled in your joints, so you may not have as much muscle mass. So you really need to look after that and hopefully grow some more, build some more muscle. And some of you may have grown up hearing, don't be active, you're going to bleed. Now with the new medication, hopefully that is heard less, that you have adequate medication and you can be more active and build this strength. So it's really important to build this muscle bulk. And as William said, you may notice things like sitting to standing, as he said, getting up on a chair, you start to use your arms, it takes a little bit more effort. You may notice going up the stairs is more difficult, or steps, or you start sitting to get dressed, little things that may change. Again, walking slower, smaller steps, because your muscle mass and strength isn't as good and you've lost a bit of confidence. And you may start needing to use walking aids. So all these little things that may be giving you an idea that you're not maintaining this strength, and trying to keep active and do your normal social events. Try not to lose that confidence to be active and meet your friends. You know, gardening, shopping, housework are all important, really. So I think, if anything, we need to all make sure, general population and those with haemophilia, that we're working to maintain and build our muscle mass and keep our confidence to be mobile.
And speaking about practical steps or any specific types of physical activity that you would recommend to maintain muscle strength?
So we're all advised to do certain amount of exercise, physical activity every week. So the guidance is generally that we do 150 minutes of somewhat hard, they say. And what that means is that you're getting a little bit out of puff, you might get a little bit hot and sweaty, but you should be able to talk, but you can't sing. So we're getting you working a little bit harder. And 150 minutes is quite a tough call, so you need to work at that. 2 lots of strength training a week, working on balance, and trying to reduce sitting time. So I think this is really key, trying to be more active, not sitting as much. And we wanted to try and preserve that muscle mass you have and build on what you've got. And you can build muscle at any age. It just it's a bit harder as you get older. And you need those muscles to support joints. So exercises could be the simple one I would give everybody is standing up, sitting down from a chair. How many can you do in a minute? Everyone's got a chair. You can stand up and sit down, time, and try and beat that each week. Try and get a little bit faster. Hoovering, housework, everyone can do that. Using the hoover, it'll take, you have to work on balance, strength to be able to do that. Even press-ups against a wall. So if you're really beginning to be a bit more active, these are some simple things. Gardening, carrying your shopping. All these things are easy that everyone can do. You don't need equipment particularly for that. And it could be joining some classes in your local community. So Tai Chi is a nice, gentle exercise that's working on balance. It could be swimming, it could be a walking group. So trying to find something that you enjoy. I think that's the key for me, is stuff that you would enjoy and you will keep doing. And if you're not sure what to do, if you have a physio in your haemophilia care centre, ask them and they will be able to guide you to help you do that. And the other things to think about, William touched on again, is footwear. Make sure your vision, if you need glasses like I do now, making sure your vision is good too.
Yeah, I think the first thing we all need to overcome is actually laziness to do certain things, because this is the worst beast for everyone. But there is also potentially a fear of movement, especially in those who have experienced pain or bleeds in the past. What can those people do to overcome this fear? Any tips that you could share?
So the fear of movement, I think, is understanding why you are fearful of movement. What is it that you are frightened about? Is it pain? Are you worried? Have you fallen in the past, as William said? Is that something that you need to think about? What caused you to fall? And really trying to identify those and work through them. Is it that you need to build strength, or you need a walking aid? And looking at analysing why that might be, and then working on that.
William, what do you usually recommend to your patients, those who have had a bleed before?
Yeah, so it can be very difficult to overcome that. And as Stephanie rightly says, yes, there's a physical element to overcome, but very much so there's a psychological the psychological element to overcome. So I think one of the big things that I suggest is set realistic goals and build up slowly. So you may find that all of a sudden you're very immobile and you can't do anything, and you're thinking, how will I ever get back to how I was before? And the reality is you won't get straight back to how you were before. So psychologically, one of the things I encourage my patients to do is set a small goal. So some of my patients who've had significant injuries, it might simply be sit in a chair for 30 minutes before you get back into bed. Then it might be stand, and then it might be walk 5 meters. And by setting these realistic, graded goals, people can make real progress. I think we're going to go on to talk about it, but it's having the right support around the person as they try to achieve those goals. And that is us as healthcare professionals, but it's also friends, it's also families, it's also having appropriate pain relief. So I think breaking that mindset of I will never be better is the first thing to do. And by setting these realistic goals with appropriate support, actually almost everybody can improve their mobility from a low point after a fall.
Coming back to my fear, what can we do if a fall happens?
So I think safety first. So if you have fallen, getting some help. Do you need to take your factor? Do you need to go to hospital? Do you need to be risk assessed for any fracture? Certainly finding out why you've fallen. Is it that you tripped over something, or are there other aspects to your health that need looking at? So from a physical point of view, yes, did you trip over something? Do you need to remove rugs and think about that? Was your footwear good? Was your vision optimized? Did you slip on something? What was the floor surface like? So really looking about why you have fallen on the physical side of things. But William will probably talk more about, are you got good nutrition, hydrated, other medicines that may be involved. So the main thing is, if you do fall, getting some help, finding out why you've fallen, and then having things in place to mitigate those risks so you don't fall again.
Thank you.
I just wanted to add to what Stephanie said. I think people's fear when they fall is, what if I can't get help? What if I'm stuck on the floor all night for 1 day, 2 days? That's people's big fear. And so technology can be a real ally here. So people can have a emergency button they could put around their neck. Smartwatches and devices can raise the alarm if people have a fall. Hopefully the person might be able to make a phone call if they have a mobile device with them. So I think it's being prepared for that fall so that you can call for help, because the really scary thing is being lying on the floor all night and not knowing when someone's coming. As long as you know that no matter what happens, I can always contact someone, I think that gives people a lot of peace of mind and a lot of confidence.
And I also make sure my patients can get up from the floor. So we practice that in a safe environment, because a lot of them will say, well, no, I can't do that. Well, so well, let's try. Can we get down onto a small stool or down onto the floor? And then how can we get back up? Because if knees don't bend, ankles don't bend, it is difficult. But can you use a little chair to get up and then work yourself up? So having that practice in a perhaps a safe environment in the hospital, and then practicing at home with people nearby to help you, so you know you have that confidence to get up.
That's really a great point, because I do believe preparing for a fall is important. We try, of course, to avoid mentally talking even about that as people, normal people, but being prepared, it is great. So speaking about multidisciplinary approach, from a geriatric perspective, William, how can geriatricians, hematologists, and physiotherapists work together to prevent falls and preserve function?
So we have known for a very long time that people with bleeding disorders are best looked after by multidisciplinary teams, because no single healthcare professional can have all the expertise. And that's what's reflected in almost all major guidelines for bleeding disorders, including those from the World Federation of Haemophilia. So whilst I think haemophilia treatment centres are used to looking after younger people with multidisciplinary teams, because we're now seeing a changing demographic in the bleeding disorders population, our haemophilia treatment centres and our bleeding disorders treatment centres are having to get used to giving multidisciplinary care to actually much, much older patients. And I think that looks a little bit different. So if we're going to look after older people with bleeding disorders well, we need to make sure we have the right people there as needed. So we've already talked about the geriatrician, the hematologist, the physiotherapist. Actually, to meet all the needs of older people, we often need a much broader multidisciplinary team. So we may need an occupational therapist who can help with aids and adaptations. We might need an optician or an ophthalmologist who can help with vision, because if your vision is poor, you may fall. We might need an audiologist to help you with your hearing. If you can't hear a hazard, you might fall. We might need a podiatrist to look at your feet to make sure your nails are properly cut, that if you have any ulcers or damage to your feet, that can be treated. You might need a pharmacist to look at your medications and tablets to say, these are causing side effects. This tablet will increase your risk of a fall. So the multidisciplinary team, I think, has to, for starters, be much broader in the older population. And for multidisciplinary teams to be effective, they have to talk to one another. So if we have a podiatrist doing a podiatry exam, a physiotherapist doing strength and balance assessment, but those two people aren't talking to each other, actually we probably don't come up with coordinated care and potentially duplication of tasks. So one of the things we regularly do on our hospital ward is we have a daily meeting where all the multidisciplinary teams sit down and discuss the patient. So we're always on the same page. I would say that there is probably a bit of debate to be had about how much of the older people's multidisciplinary care should be provided in-house at the haemophilia treatment centre. So should the haemophilia treatment centre be providing all multidisciplinary care, no matter how old somebody gets, no matter how frail somebody gets, or should that be something that maybe is sometimes passed on to other specialists? And personally, I think that's where partnerships become key. And I think if somebody is reaching a very high level of dependence, for example, living in a residential or a nursing home, I think our haemophilia treatment centres should be talking to geriatricians and talking to other specialist services outside the centre. But I think that's something that's not well understood in terms of optimal model of care.
Thank you for raising those points, William. truly important. And I do hope that all hemophilia treatment centers have a broader multidisciplinary teams. Still a dream, but hopefully soon will be reality. Stephanie, beyond clinical care, what are some simple, practical things people can do at home or in their daily routine to reduce fall risk and stay independent?
So I think, you know, within home, as I've said before, making sure that you're reducing the trip hazard. So lots of patients with haemophilia have reduced ankle movement. So actually, you're more likely to clip your toes or feet on things. So making sure the floors are clear. There's clutter out of the way. I've had several patients fall because they've tripped over things that they've left out. And making sure you have good footwear, that you haven't got slippy shoes and slippers that aren't fitting well to walk around your home and certainly outside. Making sure you are healthy, you have good diet, you're hydrated. Using walking aids, adaptations as you need to maintain your mobility. So I have patients that are concerned about using walking aids because they don't want to feel old, but actually that's enabling you to keep mobile and keep active. So they're important. Good or regular eye checks. Again, I've had patients with varifocals that they've really struggled with because they're not sure quite which bit of glass to look through, and they've fallen because they couldn't see where they were going. Looking at the terrain that you're walking on. Is it got a camber on it? Is it uneven? Just risk assessing. So lots of my patients do this all the time without even realizing. So scanning the environment and being active, maintaining that muscle strength is important as well. So speaking to your haemophilia centre for that support.
As we look to the future, what should we prioritize as healthcare providers, patient organization, individuals, in order to promote healthy aging and mobility in the bleeding disorders community? Stephanie?
So for me, as William's pointed out, that multidisciplinary working will be really important as we move forward. Our haemophilia population are getting older, and we need to involve more agencies. For me, physiotherapy provision is really important. So physio OT, that rehabilitation side of care. Lots of people don't have access, but trying to get access to that. We need to support people to be active, to increase their activity, if anything, as they're getting older, to maintain that strength, to investigate and sort of talk about that fear of falling, that fear of bleeding, pain, trying to manage that. We want you to be active as that of the general population. So a very similar message. I'm now doing strengthening exercises 3-4 times a week because I've noticed my muscle bulk is reducing and I'm mid-50s. So I will be doing that for as long as I live now, lifting weights every week. So it's finding something that you enjoy, be active, increasing that balance, being happy to change direction, walking forwards and back, joining community classes, being social still. It's very important to get out. I run a class for my patients here online every week. So we do some balance stuff, strengths stuff. They have a chat and they're seeing people like themselves exercising and having a laugh if they can't do things, but, you know, encouraging themselves. So that social support is important. And just if you have pain isn't a reason to stop being active. You can still be active with pain, and that's important.
William, what do you think national organizations, I mean patient organizations, can improve in promoting healthy aging?
So I think it's something that has been under-recognized till now, and actually a lot of national organizations don't have a lot of resources relating to this. And one of the things I'm quite proud of in the United Kingdom is that we've developed a lot of new resources for older people with bleeding disorders. So how to stay active, how to manage in a care home, and also information for family members who are critical to maintaining independence and supporting older people with falls and immobility. So I think getting those messages out there, developing the appropriate resources, and not being afraid or embarrassed to admit we're all getting older, so that we can have those conversations. That has to be a priority for patient organisations moving forward.
Absolutely. And in the tradition of our Café Talks, I would like to ask you to share some final thoughts or messages with our audience. Probably let's start with Stephanie.
So I'd say move, sit less, move more. Physical activity is essential as we age. So keeping your muscles strong, find something you enjoy doing, and keep moving.
Thank you. William?
Me, it is that falls have lots of causes, but falls also have lots of solutions. And you should never ignore a fall. Always ask, why did it happen? And then you can prevent it from happening again.
Thank you for all these valuable insights. It's clear that aging well is not just about avoiding falls. It's about staying active and supported. I hope that this session will help our community members shift the mindset from avoiding risks to staying capable and confident. Thank you for helping us understand how geriatric care and multidisciplinary approach can also play a vital role in this